to our Unclenched podcast. Today we have with us Dr. Michael DeLuke. Before we bring Dr. DeLuke on, though, I have to ask, how are you, Alex? And what's new? And please share a patient story if you'd like.
Well, okay. What's new? A lot of the same stuff. I know I sound so boring. We're planning a trip to Greece for the family. So we're going next month and just made my last reservation. So that's exciting, and that's all new. And it's going to be the core four, my kids and my husband and I. So my brother-in-law is tagging along with his kid too. So it'll be fun. I'm looking forward to it. And
Oh, good.
patients, though, I do ortho in my office, and I'm not an orthodontist, so that might be a little taboo for our guest, but I'm curious to talk to him about that. And actually, today I have an ortho patient coming in after our podcast, and we're getting her braces off, but she was a pain patient, and she never had ortho, and her teeth were aligned beautifully, but how they came together in certain spots, and she was very overclosed, so we had to open her up. But TMJ done, feels good, braces coming off, so I'm excited to do that today. What about you? What's going on with you, Pri?
Just always busy with the kids. We're gearing up for a trip to Hawaii in a couple months here. My husband's a part of the Tucker Gold Study Club. So it's like a dental study club that does gold restorations. And it's so interesting. They meet like once a month. They work on a live patient, and the instructors walk around like nitpicking. Like, you didn't remove a tenth of a millimeter here at this line angle, because they do like
Wait a minute, they
gold.
still do gold?
Oh yeah, girl, this is the Pacific Northwest. We're granola over here. People love gold.
I have nothing against gold. I think gold's great, but it's so expensive. People still pay for it.
I know. People will pay for it because it's it's a little more gentle on the opposing tooth or whatever it may be, right?
Yeah.
So we're going to the Tucker Gold conference in April, and they actually asked me to speak about TMJ. So it's a tax write-off too.
Oh, good.
So that's exciting.
Bravo.
Yeah. And then a patient that stands out to me is a guy that came in that had pain and a single click or pop. And as you know, the click or pop can be the hardest thing to get rid of, the single one. But as soon as I put his orthotic in, it was like gone. Right. But like within months, though, his teeth shifted, or his teeth didn't shift. His jaw adapted to that position, right? Because it likes it better. So when the jaw adapts down and forward, the occlusion changes. But this is like a very technical guy. Like, he fully understood it. He's like, I've never had braces. I always knew I needed them, and da-da-da-da-da. So I didn't really know who to refer him to. But since then, since he started treatment, my husband got trained with Dr. Jen Stafford and Marty. Yeah. So he got trained in the neuromuscular orthodontia. And so he's going to be starting that with my husband. And they're talking about reverse pull headgear and all this sort of stuff. So we're starting an ortho case as well. So and that's a good segue into our wonderful guest. So now let's bring on Dr. DeLuke. So Dr. Michael DeLuke is an accomplished and highly respected orthodontist. He owned and operated DeLuke Orthodontics in upstate New York from 2005 to 2023. He retired from practicing and founded DeLuke Orthodontic Coaching in 2022 to help orthodontists achieve both professional excellence and personal fulfillment. Dr. DeLuke has always been committed to early, proactive orthodontic care, which I love. And this focus has led to the development of airway-centered treatment protocols that he now teaches worldwide. Awesome. And this, along with the recent American Academy of Orthodontics AAO white paper, is what we'll be discussing today. So welcome, Dr. DeLuke.
Thanks so much, Priya. I appreciate you guys having me on the show today.
Great. I did listen to that whole podcast, actually twice, because I wanted to make sure
thank you.
I knew what we were coming into. And tell me how you got interested in the airway centric, because that's not any of the orthodontists around here in Pittsburgh are not utilizing that.
It's actually an interesting story. And Alex, just so you know, you mentioned about it being somewhat taboo to me. I am not offended by non-orthodontists doing orthodontic treatment.
Oh, thank you.
I actually I coach and train a lot of general dentists and pediatric dentists on orthodontia. And I do that. My attitude with anything you do, whether it's endo or perio, is as long as you have the training, then there's no reason you can't do it. Everyone knows everyone's held to the same standard of care, and you fulfill that. And so I know some orthodontic residency and training programs that do not give a very good education to their residents. So they come out calling themselves orthodontists, and they have the certificate to show that. However, someone who didn't go to that program but went to some extensive continuing education or works with a coach such as myself is as or more qualified than the orthodontist. So there's been a big ego thing in the orthodontic world for a long time of, I'm the orthodontist and no one else can do this. Don't really know why. I mean, I don't feel like the endodontists are that way and the oral surgeons are that way. Everyone in those specialties in perio, it's kind of like, well, yeah, with the more complicated cases that you can't handle or would be over your head, you refer them. Ortho has been this whole, like, no one can do ortho but orthodontists. So I don't have a big ego when it comes to this I'm an orthodontist, look at me, and I'm a board certified orthodontist, which I am. But I don't feel the need to exercise this dominance over the orthodontic domain. So, but it is what you said. I'm very well aware a lot of non-orthos do feel that way.
Yeah.
So for my journey in airway, it's interesting. So I started my practice in the early 2000s. Right out of my residency, I went to UConn for my orthodontic residency, which is one of the premier orthodontic programs in the world. It is where biomechanics was founded by Charlie Burstone. I actually learned from. He was still alive when I was there. And so 24 years ago now, I learned biomechanics from the founder of the field. And so I came out being a very good tooth straightener. That's what we were trained to do. And we'll talk a little bit more today, I think, about why that is and why we tend to focus on straight teeth and not growing or guiding growth and development, and certainly not airway. So we had never really spoke about or talked in any realm about airway in my training. We read articles. We read Harbold studies and things by Linda Aronson. And we read them, but we didn't tie them into our clinical work. And again, we can come back to that later if you would like. So when I got into my practice, I started from scratch. I literally hung a shingle within 5 days of graduating from my residency. I opened my own doors and I built a practice. So what I started noticing when patients would come in, I was seeing these patients at 6 years old, say 6 to 8, they'd start to come in my office and I'm like, well, in the residency, we recommended to pull teeth on these patients. And I'm looking at it. So I start to say to the parents, well, they're crowded, so I think we're going to have to take some teeth out. And the parents are like, Dr. Mike, we were kind of hoping, you being this younger doc, like, that you would have a different way to do it. All the orthodontists around here have been saying they need teeth out, and we were hoping you would be able to do it differently. So I just started thinking about it. And I was at the time teaching at UConn. I was going back twice a month and teaching at UConn. It was about just over 2 hours from where I lived and practiced in upstate New York. And I started going, this was pre-PubMed being at our fingertips on our computers or phones. We had to go to the library to access PubMed. So I would go to the health center library and I would go before or after I was teaching that day. And I would just start pulling articles. And so here is a place I'd been for 3 years studying to get my master's and my certificate of orthodontics. And I hadn't looked at all of this. And I started trying to figure out how to approach these cases from a growth and development standpoint and not an extraction standpoint. Nothing about airway at this point, like nothing. Okay. Just totally trying to get more at the etiology. I was starting to realize these patients don't have big teeth. Macrodontia, generalized macrodontia is hardly a thing. So, and if you look at the literature, there's a great study in 83 by McNamara, O'Connor, and Howe that they looked at a bunch of dental casts of patients with crowded and uncrowded teeth. And they determined that it's almost never big teeth. I mean, it's almost always small jaws. And that was in the AJO before it became the AJO-DO that it is now. Same publication, just they changed the name. So I'm looking at this and I'm saying, okay, what did they do? And then I started reading about Schwartz in the 60s and Gratzinger, and that they were going in and expanding the lower arch. And just so you both know, in my training, that was taboo. I mean, sure. I had my director say, he heard that a previous graduate who was a friend of mine was doing lower expansion. And he literally said to all of us, I should have the right to take your degree away, because when you get out of here and do stupid S like that, I should be able to take your degree. I was sitting right there.
Wow.
And so that's how ingrained in us it is that you can't do these things. So I know in both of your worlds, when you're seeing these orthodontists who are resistant to this, it's like someone who goes through military training, right? Or goes on some type of a retreat for some like a breathing philosophy. They come back. They believe these things a lot of times. It's how we're wired, and so that's what we believe. So I'm thinking, wait a minute. These people have been expanding in the lower arch for, at this point, 50 years. Like, why don't we do this? So I started trying it. I literally would put a lower expander in. I tried removables, didn't love them, meant to fix, developed my own design of a lower fixed expander with the lab, and I had an upper expander. And I was just going in and just starting to try to grow these patients. Again, totally focused on teeth, nothing about airway. And I was working. I was not having to pull a lot of teeth on these kids. I was going in and growing these jaws, and the teeth had room.
So wait, time out. They're still teaching to pull teeth?
Oh, yeah. I was at Nova Southeastern teaching for a couple of years, and multiple of the faculty, I think they did finally get rid of one gentleman recently, I just heard, but almost every case he treated, he had 4 buys pulled on. There were patients in treatment for 5, 6, numerous patients in treatment for 5, 6 years. And still with spaces. And, that's not uncommon in orthodontic residencies to be very heavy in extraction. Again, when I went, this is 24 years ago. But so when I was going to do this in my own practice, I had the unique advantage that I was my own boss. So I didn't, a lot of these young docs, remember, they go work for somebody.
Sure.
And you can't just walk in, even if that young doc has followed some of my content now and does understand thinking differently. They might walk into a practice where the senior doc was trained when I was or before. Right. And that's an obstacle. And so I didn't have that. And then I started seeing the results. And then the parents started saying to me over and over again, you'd see these patterns where parents are like, Dr. Mike, do you think it's a coincidence that they're not snoring anymore? Or do you think it's a coincidence that like they're like sleeping better? And I'm embarrassed to say, I was like, I guess it could be related, sure. And I didn't know. This is
right.
2005.
You don't know what you don't know.
Right. I'm thinking, I guess it could be related. It certainly can't hurt. As I said, obviously that at that point I still knew that the roof of the mouth is the floor of the nose. So I was like, I can't hurt. And then, it just started becoming more and more prominent in the practice. And then what happened was I got about 5 or 6 years into practice. And I was known now for doing this early treatment, and people kind of thought of me as this progressive orthodontist was doing in the community. So I was getting a lot of younger patients, and it started to overwhelm my practice. And this is actually a big thing for your audience to understand. Early treatment in an orthodontic practice is very challenging to integrate. And the reason for that is we make a lot of money straightening crooked teeth systematically. It is very profitable. And it's very efficient. Our visits are quick. They're predictable typically. When we're on our system, we know what we're doing and it runs well. And so when you start doing a lot of early treatment, you have more emergencies, you have more unpredictability, right? You have primary teeth getting loose in the middle of things and getting caught under expanders, and you've got ulcerations, and you've got tongue ulcerations, and you've got expanders embedded in the palate. I I saw it all, right? I saw it all. Porculum growing over the 6-year-old molars and trying to get the bands off. I've seen it all. So I had thousands and thousands of cases like this. So it was draining. It was starting to really stress my staff out. It was stressing me out as my practice was growing and getting busier. And that's kind of the rub on why a lot of orthos don't like to do a lot of earlier treatment. We don't get trained how to treat younger kids. So we don't have the behavior management skills. And it doesn't fit within our very profitable practices. It's harder to monetize. It is. And so I then I got an ICAT in 2014, a low-dose ICAT. And then I started developing protocols, actually even a couple of years prior to that, doing expansion. This is really important for the audience to understand and I can geek out as much on this as you want. I won't, but if you want to push me on this, I'm happy to talk about it more. But I do my expansion now. I developed protocols, which is one of the things I teach, to do early expansion with braces and wires only. No turnkey expanders, upper and lower.
What?
Yes. And you can absolutely get orthopedic change in the maxilla with light continuous forces in young patients. I have all the literature to back it up. I teach this in my courses. So that's when I started becoming airway aware. And we can certainly dive more into that if you want. But I got my ICAT. I'm now developing these arches. Once I switched to that, I started seeing the airway even more clearly, because when you use turnkey expanders, number one, heavy forces are contraindicated in children under the age of 10. Profit in his contemporary orthodontics book talked about that. There's many studies from going back into the 70s from Burt Melson. It causes damage of that tissue. Now, as you get a more mature suture, you need that force, right? You have to have heavier forces because you have to overwhelm the osseous interdigitations. When you look at a young child, 6-year-old child, their midline maxillary suture is wide open, right? You don't need to blow it out and get some big diastema. It's open already. And studies show forces as light as 300 to 400 grams of force. Ricketts did these studies back in the 70s with his quad helix. That's when the quad helix was developed. We know you can get orthopedic change with light forces. Why do we use turnkey expanders? Well, in my opinion, because quad helices and W arches and all of those things are really hard to use, and patients don't like them, and they're hard to calibrate and reactivate and really titrate. So it's just easier to use a Hyrax and maybe just turn it more slowly, right?
Yeah.
But still, every turn of a Hyrax, you're delivering 3 to 10 pounds of force per turn. 3 to 10 pounds. 3 pounds. 1 pound is 454 grams. So you're delivering magnitudes more force than you need in these young children. So I started seeing this, and here's the other thing that happens. I want you both to think, and the audience to think about this. How many times have you expanded or seen a case that was expanded that started as very narrow V-shaped arches, right? Classic mouth breather, right? V-shaped arch. And after expansion, they have very wide V-shaped arches. You see it all the time.
Right.
It's not a U.
Yeah.
My braces and wires solved that. It solved that. I would have these cases where I take the expanders out and they still have a high vaulted palate and it's still really narrow in the front and the canines don't have room. And I'm sitting here stressing out at 11 when this kid's 11, like, oh my God, the canines don't have room. I just did all this phase 1 and they, what am I going to do? That goes away when you go to braces and wires because I build with a broad arch form. You develop the arch in the anterior middle thirds so the tongue has more space. So the breathing gets better, faster.
But then when you're developing that too, then you're able to bring the maxilla forward.
So you get the maxillary teeth, yes, and that's another big thing. If you think about a lot of these kids, we won't go with the littles and the primary dentition at this point. We can talk about that certainly afterwards. But for now, we'll talk about that early mixed dentition age, which is when a lot of kids come in for the first time to the orthodontist. Unfortunately, I wish it was earlier, but that's the reality. And so when you get those kids, if you think about it, a lot of those children, they're coming in for their crowding. And so they've probably lost their maxillary, primary, laterals, and mandibular prematurely. A lot of times the centrals will force out the primary and the primary centrals and laterals because of the lack of space. So as a result of that, you lose arch length. Those central incisors are retroclined. And those patients often have very deep bites, right? They're very deep. And you have deep overlap bites with a very obtuse interincisal angle. So with expanders, even if you put a couple brackets on those teeth, it's very hard to get the right torque and the right inclination of those teeth. When you put brackets and wires, I built a custom prescription to let me get maximum torque on those teeth to be able to improve that and get the right lip posture, which helps with lip seal, which helps with all the myofunctional side of things. And they can go in, myofunctional therapy can go in and start working while I'm working because there's nothing on the tongue.
No,
so
there's
nothing impeding them from starting to work with the children. And then as far as the maxilla coming forward, you do see, and I have the pre and post CBCTs to show it happening, you do start to see that pre-maxilla develop. See, a lot of these patients aren't as maxillary deficient as they are pre-maxillary deficient, if you really look at them. And the braces and wires develop that pre-maxilla. And the tongue just starts to have space. It's literally... Just one more thing, and then Priya, I want to make sure I get to what you're asking on this. But when I started seeing this happen, you have to realize this is a UConn trained, like biomechanical geek tooth straightener, and this is sacrilegious to anything that I ever learned. And I started seeing this happen, and I'm going, I couldn't believe my own eyes what I was seeing happen to my patients. I actually had the parents signing consents in the beginning that I acknowledge that this may not work.
Yeah.
And Dr. DeLuke may need to put turnkey expanders in because I didn't know if it would work, but I was like, it's not going to hurt anything. But I never once did I have to revert. And then I just started pushing the envelope of how severe the cases were I tried this on. So.
Now that's so interesting.
It
I got a
is.
lot to
It
say.
is. I
But
and
go
Yeah.
ahead, Priya. You had
well,
something.
I have
Go
a
ahead.
question. So a lot of people say, well, the maxilla can be expanded because there's the suture, right? But there's no suture at the bottom. So a lot of even orthodontists believe that it can't be expanded. So can you talk a little bit to that in like layman's terms so our viewers understand how this can be expanded?
Absolutely. And I'm glad you brought that up. Thank you. So you're not expanding the mandible. You're correct. The mandibular midline suture is fused about birth. So you're not getting orthopedic expansion unless you did a mid or parasymphysial cut. And some do
Right.
that. And you do sort of distraction or osteogenesis, especially in patients with certain syndromes. But that's not what we're talking about as the norm. What you're doing is you're getting dental tipping and dental alveolar remodeling. And so what happens is if you look at the ABO, American Board of Orthodontics criteria, they specifically state that the curve of Wilson, which for those who are watching, kind of my two fists being the lower molars in a coronal slice, that should be flat. And that the buccal and the lingual cusps should be no more than 1 millimeter in discrepancy. So if you think about the patient that has a transverse deficiency at a young age, let's just stay with that, those lower teeth are all rolled in. And why are they rolled in? They're rolled in to meet the narrow maxilla. So I do a thing when I teach in a lot of the courses when I'm traveling lecturing, I call patient A and patient B. Patient A, let's just pretend, has a narrow maxilla and has a very nice mandibular arch, very upright molars, level curve of Wilson. That patient invariably has a bilateral posterior crossbite because the maxilla is narrow and the mandibular arch is fine. Orthodontists will treat patient A all day long at 6, 7, 8 years of age. We won't even question it. Now let's take patient B. Keep the same maxilla, but roll the lower teeth in to fit that maxilla. So we get rid of the crossbite, right? Orthodontists will now extract on that patient because they don't have a crossbite. So you don't treat something without a crossbite. See, they're thinking of it the wrong way. My theory is patient B, even though they don't have a crossbite, has a more severe malocclusion because patient B has a problem in 2 arches. Patient A only has a problem in the maxilla. So to your point, Priya, what I do with that is I take that patient B with those rolled in teeth and I'm just uprighting them over the bone where the ABO says they are supposed to be. And I've never seen anybody, and I've spoken to rooms full of 150 orthodontists on this too. And I say, speak just like this. And I will say, did someone want to defend the stance that lower molars, lower posterior teeth should be rolled in at an angle, not straight up and down, vertical axial load over the bone? Does someone want to try to defend that? No one does, because that would be crazy. That we know occlusion is not supposed to be built with lower teeth that are cantilevered off the bone. I mean, that's why you don't restore an implant that way, because it's not conducive to appropriate force load and stability. So we know that, but when we're so dogmatic and essentially indoctrinated by our training that we're told you don't expand in the absence of a crossbite and you can't expand the mandible, right? But you can upright and expand posterior teeth. Now you want to know something interesting, because I love to geek out on literature. If you look back at the orthodontic literature going back, into the mid 1900s, orthodontists have been expanding lower arches with lip bumpers for decades.
Oh.
Of course, go look. If you look, just say lip bumper. Go Google or ChatGPT lower expansion lip bumper. You'll find articles going back to the 50s and 60s on this, because they were doing it. So the hypocrisy is pretty profound in this. It's like, okay, wait, so I can take a lip bumper, expand that, put that in the molars and widen it out and get the cheeks away so that the tongue can help the lower teeth upright. But I can't actively put an expander in and do it. I can only do it with a lip bumper. And again, when I question my ortho colleagues on this, they don't have an answer.
Anything to say?
Oh, you've got some guts. Like going in there and challenging out. You've got some guts. I love it. Well, can you explain how low tongue posture and mouth breathing affect facial development versus correct tongue posture and nasal breathing for our viewers?
Absolutely. So believe it or not, that's controversial in the orthodontic world as well. But again,
This is what I don't understand. It's controversial, but what you're going to say makes sense. So why can't we just go with common sense with a lot of these things?
I wish I knew.
Because it's not
Honestly, Alex, I
evidence-based,
wish I
Alex.
knew.
It's
Yeah,
not
I
But
mean,
then when
evidence-based.
you talk about evidence-based, you listen to how he explains
I
evidence-based.
know.
Their evidence-based is not really evidence-based either.
correct. Yeah,
It's
the
dogma
evidence
and it's
based
ego.
side. Yeah, I mean the evidence
Okay,
based
go
side,
ahead.
as I went
Sorry. I
over
just
in
But
had to
my.
interrupt.
you know what, Dr. DeLuke, I will point out that first off, you have guts, one, but two, you fit the demographic that they'll listen to. And I hate to say it, but as like a young ethnic woman, like I tried to talk to a few orthodontists in the area as gently as I could. I tiptoed around it and they just shut me down. And it sucks, but I'm just so glad that we have someone like you in this space. You
Well,
look the way they want you to look, and I love it. I mean, I
I
am here for
appreciate
it.
that. I appreciate that, but they don't like me
I was going
either.
to say they don't like him either.
Don't take
Come
it
on.
personally
Don't pull
as
the
it
ethnic
being.
card. They just don't like anybody that doesn't
They
follow
Yeah.
the
are
original.
just so dogmatic.
Yes, they will come at anyone who challenges their dog, no matter what they look like, no matter what their sex or race is. They will.
Right.
You're
I
not
mean,
able to talk them into anything?
oh, well, the ones that are established, no.
No.
They come at me. I mean, you should see if you saw some of the things that these people say about me in the online groups. I mean, I just had someone sent this to me. And again, I'm open book on this stuff. Like I'm not hiding anything. This one orthodontist I think he's on faculty at a residency in Texas. He said that I'm an effing moron and my biceps are bigger than my brains. So so don't take it personally based on what I get it. I get it just as much as anybody. They'll make what to you would be interpreted as a comment about you being a female. They'll make about me being, a fit male. Like they don't, it's not specific to any group. It's the fact that they don't want to be questioned. And who am I?
They don't want to be
Even though I am a
questioned.
board certified orthodontist who practiced in my own practice for almost 2 decades and has taught in residencies for 22 years now, and went to UConn, was chief resident at UConn. Like it doesn't matter. And I know what you're saying. Like I should be the one that they'll listen to.
Yeah, of all people,
They don't
like
want to
you.
change.
That being said, the younger docs, I have an amazing following of young docs in my residents. I mean, I have trained so many residents who now think this way and believe in this. And they're the one I told you about that emailed me just before we hopped on this recording on the podcast. He is up in Montefiore. He's like, I can't believe what a difference we made in this child's life by detecting the airway problems early, and he got him the ENT. And so, they listen to me, and I have an advantage because of my time and experience and credibility, because I can sit there and show them cases that I treated this way for many, many decades and show them the stability over time and all of that. So that gives me an advantage with the younger docs. But when it comes against the ones that you're going to their offices and they're hating on you, they're hating on me just as much. So
It's
don't
so
take it personally.
sad. Like, shouldn't we all just continue to learn forever? Like,
I would think so, but it's interesting. I gave a talk at Airway Palooza in fall of 2025 on this, and my topic was why this is a challenge in the current state of orthodontics and airway focused care. And one of the things I realized as I was preparing that talk and spoke about it, we're all very resistant to change. It's just how we are. And if you think about it, if you went, you go to school for all these years, you go into this debt, you practice this way, you're in your community. You've been telling all of your staff and all of your community for all this time that there's no relationship between airway and orthodontics, that pulling teeth is the right way to go. You've done it on your kids. You've done it on your siblings' kids. You've done it on your friends' kids. And now, 20 years in, you're all of a sudden going to be able to accept the fact that was wrong all along, and now change your entire way of practicing, your systems, your diagnostics, invest in new technologies, change your new patient exam process, all your scripting. Think about it. It's a Herculean task to undertake for most people. And so I'm not giving them a pass. I'm really not. That's why you'll always hear me say, I will never tell anybody how they have to practice, because I've been there and I know how hard it is to run your own practice and do it well. I will not tell you how to practice. I will tell you how I think you should practice and how I think you could benefit from practicing, but I won't judge you if you choose to do it differently. Where it crosses the line with me is when they tell me or you all that we shouldn't be doing it that way.
Right.
And that's where it crosses that line with me. It's like, look, I'm not going to go out and parade you around your town that you're doing things terribly. I would never, even when I got second opinions from people who were extraction orthodontists in my practice, I never put them down. I never was critical of them. I just explained I have a different philosophy. Their way of doing it is a more traditional way. I have a little newer way of doing it, and that's that. But that's why I don't take kindly when they are trying to shut me up. That being said, if someone wants to practice that way and that's what they put their head on the pillow at night doing, I'm not here to tell you you're a terrible person or a terrible orthodontist. I'm just here to try to teach people that there's another way.
Sure.
Well, that's like the reason that I learned orthodontics, and I went to different people and different programs to try to pull together. Some were taught by orthodontists, some were taught by non-orthodontists, and I tried to pull together what worked for me and what recipe worked. And I'm having a little difficulty sometimes with the younger, and people are seeking me out because they know I look at the joint, I look at the airways, I look at the teeth. I want to give them a beautiful smile, and we're looking at the TMJs and all of that kind of stuff. But the whole thing is that once you see change, like you saw change when you were in practice, how do you unsee it and go back to your old mode? Exactly. So it's like your boyfriend, once you sleep with him, you're not going back to shaking hands, right?
Ooh.
Right.
Well, it's true. So
Yeah.
it's like you can't take those steps back. And that's why I get frustrated too, that people don't even want to listen. And the reason I went to learn is because I went to orthodontists in my ear, and I'm like, look, I treat TMJ. I want to get their joint in the right position, get them out of pain. I need you to then move the teeth to that position. So then I'm going to have a happy patient and we're going to look great. So I need you to go to this class. Oh, Alex, no, I'm too old. Oh, Alex, come on, you can't do that. Oh, so then do you think I wanted to bend wires and all? Heck no, I'm busy enough doing other stuff, but nobody would do it. And I couldn't leave these people in orthotics for the rest of their life.
Alex, that's exactly what I think to a person, every non-orthodontist I train and coach says what you just said. They don't want this whole thing out there that, these general dentists and pediatric dentists are just trying to steal all the orthodontic work. I've never seen that. In fact, I feel it's the exact opposite. I feel it's that orthodontists are ceding this territory to non-orthodontists because we refuse to do it. And this is what I say openly. It's because we make so much money straightening crooked teeth. Once you get it down in a system in your office, however you do, whether you're extraction, non-extraction, Damon, expanders, early, whatever it is you do, once Invisalign liners, angel liners, whatever, once you master it and you create office systems to do it, it becomes very profitable and not that challenging. Meaning some cases will be harder than others, obviously, but you can do it and really get good at it and be successful with it. So then you come in, Alex or Priya, or either one, you come to me and you say, hey, how about you start treating kids a little maybe younger? Or maybe
that's what I want to do, because I get people all the time calling and I'm like, okay. And then I look at what do you think of MyoBrace? Are you familiar with MyoBrace?
Sure. Yeah, absolutely. Yeah.
So, we'll start in a MyoBrace, and it's just something for me to maybe try to help the tongue go in the right position and help the lips and stuff. And so I'm like, okay, so I feel like I'm doing something, and I'm doing the right thing, and the patients are compliant, and the parents are having better sleep and what have you. But I know there's more, and I don't know. I got to learn it. I got to figure that out. And maybe you're the guy to teach me.
Yeah. I would have, so I guess I'll take it in two parts. MyoBrace and functional guidance, growth guidance appliances. I'm with you. They're not stopping the need for ortho. I really don't like when people say they eliminate the need for ortho. They eliminate the need for expansion. That's kind of a pet peeve of mine. Nothing, even really well done early treatment doesn't eliminate. You can't guarantee it's going to eliminate any tooth straightening down the road.
I agree.
Minimize the severity, but what, like you said, they're great for encouraging proper oral motor tone, especially if someone doesn't have access to myo. They work even better if they can have access to myofunctional therapy, but not everybody does. The residency I teach now, where I'm the director of the orthodontic component of the pediatric residency, we treat, it's a federally qualified health center. There's not a lot of our patients are underserved and they can't pay for myo. So we have to have other ways. So I'm actually looking at bringing in some of these early growth guidance appliances into the curriculum to try to help at least do something to get proper tongue posture and lip seal and nasal breathing. You have to be very careful with those appliances that if you don't do the correct diagnostics, and the patient has obstruction of the nasal passageways, whether it's turbinate hypertrophies or allergic rhinitis or enlarged and hypertrophied adenoids or tonsils, if they can't nasal breathe at all, then those appliances will fail. I mean, they're not going to harm them. They'll just spit them out and they're not going to wear them. And so a lot of the compliance issues with those appliances are because the poor kiddo can't breathe through their nose.
Correct.
And now you're telling them to close their mouth and they're like, yeah, that's suffocation.
You gotta live.
So, you gotta live. So people are like, my child won't wear it. Well, yeah, obviously there's some kids who just won't wear it, but most of the time it's that the kid can't breathe through their nose. So that's a big part of those, which is why I always say to people, if you're going to use them, you have to ideally get a low dose CBCT on these kids. Sure. Make sure if you need to see allergy or ENT or both to get the nasal breathing, and then you can start to use them as a nice adjunct. So when it comes to me teaching people on it, yeah, I mean, I literally built my curriculum because, and this is honest truth, like I had so many parents saying to me, Dr. Mike, why are you the only one doing this? Why are you the only one thinking this way? I had a waiting list of people 6 months long just to get in for a new patient exam with me. And I'm not saying that in an arrogant way, but it's because I was the only one in my community doing this. So parents were lining up to get their child because they knew I was taking these 3D images. I was working with ENTs and allergists. I was detecting airway problems in these young kids. And then I was helping get them the care they needed. And we were transforming these kids' lives. And so people saw me as more than just a tooth straightener. They saw me as a physician of the head and neck, really, that was helping their child thrive. And once you do that for a few patients, and I was doing this before it was social media was talking about this. So this was literally word of mouth. And this is literally, soccer field, lacrosse field stuff that it was just, people would just talk about it and say like my so-and-so, my cousin or my friend or neighbor, they'd call my office and say, went to Dr. Mike and he detected a breathing problem. I think my child has the same thing. I never advertised it. I never marketed it. Mm-hmm. I never said I was treating airway. I actually don't, this may be something I don't know if your audience agrees or disagrees, but I don't like the term airway orthodontist. I think every orthodontist should look at the airway. I don't think
they don't.
They don't, but I think we need to make it that every orthodontist should be airway aware. It shouldn't be like this thing where it's like, I do something differently. We don't focus on, it's not like a crossbite orthodontist or a mid-face deficiency orthodontist. Like we look at these things, or an underbite orthodontist. That's part of our job is to look at those areas. And I don't say I treat airway either. I've never said that. I don't treat airway. I don't guarantee that my treatments will solve airway. I normalize anatomy. I treat patients and I normalize anatomy. And by normalizing anatomy and getting them to the appropriate medical and or myofunctional therapy colleagues to address any of the structural and functional issues, you almost always will improve the airway and get them breathing better. But to me, I think a big part of this is the orthodontists are so against this whole we don't treat airway. And I'm like, you're right. I'm not. I'm treating the patient and I'm normalizing anatomy. I'm not expanding patients who are super broad to try to fix an airway problem. If their anatomy is normal and they have really good tongue space and really good structure, and I'm not just going to take a patient with 45 millimeter width molars who's got perfect occlusion and just go blow them out to try to solve an airway problem.
Correct.
Because to me, that's not the etiology. I'm super focused going back to the beginning. I'm all about the etiology. So in my diagnostics, I look at that patient and I'm like, wow, transverse looks really good. Tongue space looks really good. Swallow looks really good. Take a CBCT. Oh, well, that patient has turbinate hypertrophy and mucus rimming in their sinuses and concha bullosa. Well, this is an ENT allergy patient. So let's get you to where you need to go. And that's really the last thing I'll say about that is that gets back to what we were just talking about. Stop and think about the average orthodontist who is literally just taking a pan and maybe even a Ceph, some don't, and looking at the patient for a minute and not doing a full history. because that's what's happening out there. And now the two of you walk into their office and they're like, you need to start earlier. And they've never seen young kids. How many of you have heard orthodontists say that, oh, well, don't start too early because they're not behaviorally ready yet.
Yeah. Yeah.
Right?
Sure.
Well, why aren't they behaviorally ready? Because probably they're not sleeping well.
They're not breathing well. Yeah.
They're not breathing. So again, it's just a mindset shift.
Well, and then the relationship too to the ADHD and the airway and the breathing.
Right.
I mean, that
Exactly.
you can't fight that.
You guys, we got off track. We never talked about tongue posture.
Tongue posture. I know.
Okay, go ahead.
Posture.
Reel me in.
I promise.
Go ahead.
I won't let you forget. And no, I know I get so excited talking about it too. But okay. So again, not sure why this is controversial. There was a gentleman, Donald was, I believe, the first name, Enlow, and he was an anatomist who was really involved in the orthodontic field. I think he was the director or chair of the program at Case Western, I believe is where, but he was involved in orthodontics even as an anatomist. And so he had done a lot of research in this and muscle function and tongue function and the oral, the relationship between muscles of mastication, muscles of facial expression, tongue posture, and dentition development and growth. He was really big on that. And so there was an article that a gentleman named Principato, who was a physician, published in 91, otolaryngology, head and neck surgery, and was referencing Enlow's work. And they showed these really cool diagrams that actually in that review I did of the AOA paper, I showed this, that shows that when it's a coronal slice of a schematic, and that when the patient is closed, the tongue ideally is sitting up towards the palate, is sitting up against the palate gently and putting light forces up and out on the maxilla. That's why we call it tongue nature's expander. And the buccal musculature is slack. It's kind of got a little slack in it, right? It's not pulled. When that patient opens, the tongue drops because it's attached to the mandible, not the maxilla. So it descends and now can't be putting that upward, outward force on the maxilla. And additionally, that buccal musculature and even the masseters will stretch. And that puts an inward constrictive force on the arch. So you're getting two things happening when you have open mouth posture and low tongue posture. You're getting the lack of or the deficiency of the tongue's role as expanding up and out on the maxilla. And you're getting the added inward directed forces of the orofacial musculature. And those two things are what redirect the craniofacial growth and development of our patients to be narrower. And interestingly, I know that sounds like it should be common sense and it's all over the literature, but a lot of orthodontists actually disagree that the way you breathe or function impacts the way the face grows. And I don't even understand where it comes from, but I literally argue with them about that. And I will quote literature. I mean, I could sit here for a half hour and just quote studies that prove that it's true, but they refuse to acknowledge that. So I don't know what your all experience is with that and why you think that's controversial, but that's the physiology of it.
Well, what do they teach in orthodontic programs? Like, are they saying anything about where the tongue sits? Are they just saying nothing about it? Are they saying that this isn't true? Are they, obviously they're not saying it is true, but are they just saying?
Yeah, that's such a good question, Priya. It's such a good question because we learn most of this. We learn most of this in the textbook, in our lit reviews. We talk about these things. But here's the thing. When we go to our clinics, and I'm dealing with this now with the pediatric residency and the challenge that we're up against and trying to figure out solutions for this, this gets it might sound like I'm off topic, but it's actually directly relevant to the question of why orthodontists aren't learning this in the residencies and doing this. So most patients who present to orthodontic clinics, resident clinics, are on Medicaid. Most, not all, but most, a high percentage. Have you guys heard of the HLD index or the Salzman index?
What is the Salzman index? But go ahead and explain it.
So the Salzman index was developed in 1968. It's in the AJO, was published. It was when Medicaid was starting. And what it was, they were trying to figure out who to cover for orthodontic treatment as part of Medicaid. And so it was an index of handicapping need. It was a handicapping assessment index. And handicap in those terms meant social handicap or severe functional handicap, like cleft craniofacial, or severe crossbite, underbite. Like they were recognizing the real severe issues. But it was a way to figure out if these people would be able to get a job and function and thrive in society if their teeth were so crooked, right? So it was a very reactive index. It was based on, okay, let's look at permanent teeth, older kids, and say, of these teenagers, are their teeth bad enough that it could hurt their ability to thrive in society?
Wow.
And so that is still to this day, the Salzman is now the HLD. I can't say every state. I would be willing to say almost every state has their own version of the HLD index. And it's almost all similar. And it's usually 26-ish points that they need to score. And here's the thing. They don't score the primary teeth. So it is almost impossible to get an early treatment case covered unless that patient has like just a full circumferential crossbite, like the whole maxilla is inside the mandible, right? Yeah. Or it's a patient with a syndrome or a cleft craniofacial anomaly. But they are not covering. But guess what they will cover? Extractions. Medicaid will pay for the teeth to be pulled. So we do screen 6, 7, 8-year-old patients in orthodontic residencies, but we don't treat many of them because the state won't pay for it because most of them are Medicaid. So we are trained in our programs, and I've never heard anyone else say this. So I don't know. This is really just my theory, but I've been in this game a long time. Not only, I mean, if you count my residency, we're going on 25 years that I've been at this. So it's been and I've been teaching and practicing in some combination thereof the entire time. So I've seen it at different programs in different states. This is a problem. And so they will then let us send the patient to get their primary teeth extracted and then the permanent teeth extracted and then go through years of ortho to try to clean it all up. And that's why in your average orthodontic residency, you've got a large number of patients who had 4 premolars extracted and have been in treatment for 3 to 4 years. Because that's what we're forced to do. So now think about it. Where does our research come from? Orthodontic residencies. Well, how are they going to do research on early treatment when we're not doing early treatment? So the system is broken fundamentally, and it's always follow the money on this stuff. And so,
well, that's all of America. That's what we are.
It's everything. It's everything. It's follow the money anywhere. And I say to people oftentimes, I'll say to my ortho colleagues when I speak in front of them, raise your hands if you disagree with me with this statement. If insurance went 180 and started reimbursing more aggressively for early treatment and stopped reimbursing for adolescent treatment, do you disagree with me that more orthodontists would start doing more early treatment?
Sure.
And to their credit, not a hand goes up ever. Yeah. Because of course they would. If you weren't getting paid by insurance companies to treat adolescent kids, or even if I was never a par provider, but patients still got their benefit. So when we filed the claims for them, so if they have a $2,000 ortho benefit, lifetime benefit, and the insurance company said they don't get it for adolescent treatment, they do get it for early treatment, of course orthodontists are going to start doing more early treatment. All of a sudden, this whole thing will flip upside down. So it's about the money. It's sadly, and as I said before I started doing it the way I do it with braces and wires, it was hard to monetize. What I made on my early treatment cases versus what I was making on my comprehensive treatment, I mean, it wasn't even close. So I just believed in it and I knew it was the right thing to do. So I was dealing with it. And then once I figured out doing it with braces and wires, it does become profitable. And that's something I teach people too. It becomes profitable. I systematized it. My revenue per visit went way up. But I mean, that took me 7 years and 8 years almost into practice to figure all that out. But I went 7, 8 years doing it the other way and not making much money doing it. And most orthodontists, I hate to say it, they're just not going to do that.
They're not going to do it.
I have a question because we're both TMJ, and I see a lot of times in my practice, people have straight teeth and they come in, but they're very overclosed. So then their jaw is trapped back. Their sleep is awful. Their joints are hurting. Their headaches, neck ache, what have you. So are you guys not taught to open bites up so the jaw can come a little bit forward?
Why are they so closed? I see so many finished cases where it's such a deep bite still.
And then they're in a plethora of pain and discomfort.
Yeah. See, I'm not okay with that, but I'll give you my theory on why that would be. I was I was literally just going over this with my wife earlier because I'm preparing to talk to a study club of orthodontists in a couple of weeks, and they submitted some questions ahead of time. Again, to the point we were making before, Priya, like very like coming at me, like how do you prove this and evidence for this? And I love that. Like this is what I love to do.
Right.
But I was preparing some stuff for their talk, and I was looking back through some of my cases, and I just said this literally this morning to my wife. I was like, gosh, I forget how much crazy awesome stuff I did as a tooth straightener because now I really live in the world of early treatment and airway and growth and development. But like I made my name in my community initially as like being a really, really good orthodontist and tooth straightener. And I love getting a perfect occlusion and beautiful broad arches. And people called it the DeLuke smile in my community. I was known for that because I take a lot of pride in the way I was as an orthodontist, which again is kind of weird because I don't do that part anymore in my teaching and residency. Everything's basically early treatment now. But so I would not finish cases that way. That being said, if you were to say why do some, there's two reasons I could think of. One, some people, and this isn't even a criticism, I think we could have the debate over what you do about this, but they'll leave patients a little deeper to preserve the smile arc. And so they don't want to tuck those incisors up too high. And sometimes opening a bite, you can do it either, and there's multiple ways of extrusion or intrusion of each arch, but without boring the audience on the technical side of that, there's a component that's going to be intrusion of the lower anterior teeth or intrusion of the upper anterior teeth or extrusion of the upper or lower posterior teeth. And if you intrude the upper anterior teeth too much, you tuck them under the lip and you flatten the smile arc. And so some people, there are philosophies in our profession that they bond the brackets very, very gingival. And I'm not knocking this. And they create beautiful smiles. And sometimes you can get a really amazing result with it. They bond the brackets very gingival to maximize the extrusion of those teeth to really get a beautiful smile arc. And when you do that, a lot of times you'll leave that patient deeper.
I see.
And that's one reason I've seen cases left deeper. The other reason that you'll see that would be laziness, and they didn't correct the class 2 deep bite. And so those patients, if they're deep, they'll be almost invariably class 2-ish because it's hard from a mechanical perspective to get a patient. If you get perfect ideal overbite and overjet with class 1 canines, that's a perfect occlusion. You're not really going to have a challenge. But if you deepen that bite, you almost invariably have an AP discrepancy to allow that, because if you didn't, you wouldn't be able to deepen it. So those patients will be a little class 2-ish. And that's, to me, that could be certainly orthodontic laziness, meaning they get the teeth straight, but they don't fix the bite. Remember, straightening teeth is the easy part of what we do. Bite fixing is the hard part. So yeah, that's not acceptable in my mind. I mean, for someone to leave a patient, if they could explain it for the incisal arc and all that, and that's their philosophy of treatment, again, you could have that academic debate with them of which was better for that patient.
But in the process of using that, you're creating pain. So you're ignoring totally what's going to come because you did it like that.
Yeah, you have to be cognizant of that. And that's why I never left cases deep like that, because I just, some people thought mine sometimes were had insufficient overbite. I always made sure I had guidance, but I didn't like leaving them deep because I did have a significant awareness of TMD and the issues you could cause by those patients pounding on it. The other part of that is the incisal angle. So I'm really big, and this gets, again, kind of, I won't get too technical on it, but the torque you put into your brackets and the prescription you use. If you use aligners, it's a lot harder to get good torque on your anterior teeth. It's just, you can do it, but biomechanically, you have to really know what you're doing, moving teeth with plastic. And so a lot of the cases, like when I started with the ortho residency at Nova, when I went in, their Invisalign cases were like all of them deep, just what you described, right? And they're like all these problems. And it's because they didn't understand how to get the right torque and inclination of those incisors. So if you think about incisors, if you take, just like we talked about with the patients that were young and lost their laterals early, those teeth retrocline and you get an obtuse interincisal angle, right? That will leave you deeper. If you procline those teeth to a better interincisal angle, you're going to have a shallower bite. So again, it could just be their orthodontic mechanics. They're not as particular on doing that. But that to me is not okay. I would have a hard time defending someone who's leaving all their cases.
And a lot of times too, I'll see finished cases. And this is one reason too why I decided to do my own ortho. I'd see finished cases and I'm like, well, hell, I can screw them up like that too. I myself.
You guys, I don't know if you guys are either your country music fans, but the Trace Atkins song "Hell I Can Do That." Have you guys ever heard that?
I'm like, oh my
It's great.
God.
Yeah, it's
But,
that exact concept. Hell, I can do that.
So
you know,
funny.
and then I don't see a lot of canine guidance.
Yeah, I don't see
I'll
that
see
either.
a lot of, and I'm
I
like,
just see I see anterior open bites, tongue thrusts. None of that was addressed. It's so frustrating.
but I think
I
some
had
of that comes later. I don't think
yeah,
a
it
lot
does.
of
But I've
times
seen
they're
finished
finished like
cases.
that.
I've seen
Yeah.
finished cases where there's an anterior open bite. Like they come from the orthodontist to my office, and I'm like, this is ridiculous. But I had a question. In ortho residencies, do you know if they teach like the way the teeth fit together, like cogs on a gear, that impacts condylar position? Do they talk about that? And like,
Yeah. Oh, yeah. That's ad nauseum. I mean, that's not debatable that that's taught in ortho residencies. We are hyper focused. Probably, again, we focus on orthodontics. So if someone's not doing that, they're just being a lazy orthodontist, truthfully.
Okay.
That's not okay. And as someone who practiced and treated thousands, tens of thousands of patients, and I mean, you could literally call up people that were up in my area in the Albany, New York region and ask them how my case is finished. I was known as being a very particular orthodontist with my finishes.
Okay.
And I say that proudly, not boastfully, but so I wouldn't defend anybody who's leaving. Again, things happen. You're not going to have every case perfect.
Sure.
But whenever I had a case that wasn't that way, I sent a letter always to my GPs or pedos afterwards with before and after pictures and radiographs and everything. In that letter, I would explain I was unable to achieve, these objectives because of these reasons in this particular case. And it was rare that happened, but there are obviously things that happen, or patient compliance, patients or they're breaking things all the time, or they're not wearing their bands or whatever. You can have those challenges, but those should be the exception. If you're seeing a lot of that from a particular orthodontist, that is a sign that someone's not doing high quality orthodontics.
Sure. Okay.
I'm just sitting here thinking, and I just still have so many questions, like why they don't do the common sense, and we'll never know that answer. And I don't know if it'll ever change. And I know your societies and your journals and things like that, sometimes the articles seem to be maybe a little bit askewed with the references and all that kind of stuff in there. And so, I guess we just got to keep doing what we're doing and plowing forward. And
he's training a whole new generation.
I know. So
hopefully
that's what
then
I
we'll
need
see
to
the
know.
change.
Tell me about this training. Like, how does it work? Do you have, because I am interested in that. So do you have a phase 1 training, a phase 2 training? Do you have different classes, or do
Where is
people
it?
all have to start in the very beginning? Or if you've been doing ortho, you start at this, like, how's it work?
Absolutely. Yeah. So a lot of the training I do, there's resident training, obviously, that I'm teaching residents to do this.
No, but
in
I
my
mean for
coaching
me,
side,
for
for
somebody
the
who's
private
already
practice,
doing. Yeah.
I have, so I initially started building courses about 4 years ago. I got my ADA CERP recognition. I started building online CE courses.
Okay.
And I was doing that. And then there's been a demand recently. It's actually interesting timing. A orthodontic colleague of mine who is in Fort Lauderdale, I'm over in Naples, and I trained him on this arch wire expansion and all of them airway. And he went to a great program, but learned nothing about early treatment, as most orthodontists don't. And we were on faculty together at Nova. And so he started doing it in his practice, and he couldn't believe the results he was getting, and the parents he just couldn't believe what was happening. And these parents are like, oh my God, my child, they're a different kid. So he started implementing the braces and wires phase 1 expansion. And so he said to me, we need to do a course, like an in-person course. And I said, all right, if you want to use your office, we'll do it. So we are actually November 13th and 14th this year. We're holding our first in-person course. We just announced it. We're limiting it to 20 docs because we want it to be intimate. We want it to be hands-on. It's not going to, as part of that course, I'm actually giving everybody, included in the tuition, is my full 26-hour online curriculum that everyone is required to take prior to coming to the in-person, because the in-person is going to be one day in a meeting room. It's actually on the beach in Fort Lauderdale area, in a hotel there. And then the next day, day 2 on the Saturday, is in Daniel's office, where you're going to get to watch me do this on patients and him work with patients and see it go live, see how we do it. So we'll treatment plan on that first day. There's going to be case treatment planning. We're going to all go around and we're going to break down everyone's cases together, looking at how we analyze these patients, how we understand how to build the treatment plan, how we communicate this to not only the patients and parents, but our team members, so that people can start implementing this right into their offices. And I've trained a lot of people on this over the past 4 years, hundreds, but it's harder when I don't get them in person, because they end up having to do a lot more remote coaching with me to kind of like guide them through their first cases. Now that's going to be, they take the next few months to take the online course, and which is take it at your leisure. And then in the in-person, it's going to be really focused. And then I'm actually going to create on my website a locator, a doc locator, that everyone who takes this, because I get a lot of people who reach out to me through my podcast and my social media to say, do you know a doctor in my area? Now I can direct them. Once they've gone through that training with me and they've been in person for a weekend, I know that they're proficient. Now I can start to say, hey, look, there's this doctor in this community or this doctor in this community. This is who you want to reach out to and build that network. So yeah, I've built that because I've changed so many. I mean, I have a general dentist. Scott won't mind me mentioning his name. Scott's amazing. Scott Province up in North Jersey, New York. I trained Scott on this a few years ago. Scott sends me cases. He'll just send me text me a before and after of what he's doing for these patients using the technique I taught him. And he wasn't a believer. He was like, there's no way, it has to be expanders. And now Scott doesn't touch an expander on these young kids.
Well, okay. So this is a question for you too. Now my team, I have a very small team, and my team goes to almost all of my classes with me, because they're talking to the patients, and they're trained like to answer the phone, to assist me in the back, to do ortho, to So like I like always go with my little harem team, because
oh my gosh,
I do, and you know that.
I know, I love them.
And because I want them to understand what's in my head, because I never get time to go back in the office and then go through everything with them and say, okay, this is exactly what we're going to do, blah, blah, blah. And they just need to have a handle on it too. So do you have a course with them, or are they invited to come with me, or maybe one team member at least come with me?
Yeah, no, that is a great question. And of the people who have registered so far, no one's asked that, but I love the question. And I'm a big believer in having your team on board. Actually, the online portion of this course, literally a whole section is devoted to team training, in not only the clinical, like how to train them to actually be your auxiliaries and help this clinically, but your TC, your coordinators and your patient coordinators to be able to script them. That's a big part of it. So there's some of that, and you can obviously share that with your team. Yeah. But as far as bringing them in person, that's a really interesting idea, Alex, and I'd be totally interested to figure something out. If you want to come to it, we can figure something out. Obviously, I can't have a huge group, but we get 1 or 2 people that are really important to you. And Daniel, my business partner in this, the orthodontist on the other coast, he's so great, and he's younger, about 6 years out. He's an innovator, and we both want to make this. This is the first one. We're going to do this every year, hopefully, and we want to make this something really special, where we build a community of providers who can provide this service and help patients. And so we'll figure something out. Yeah, message me afterwards, email me, and I'll figure something out.
Because and you said that's in November.
Yeah, mid-November in Fort Lauderdale. So we did a time of year when it's nice to go down to Fort Lauderdale, and good time of year. And we got a really good rate on the hotel. No, I have some. We just announced it like 2.5 weeks ago. So there are spots open.
Okay, I'm gonna.
People you want to send. It's starting. If I'm getting more people now, and we actually have $1,000 early bird bonus on the link. If people go to earlyorthotreatment.com, that's the registration page, and all the information's there. Everything it includes. But we locked in a really nice rate of $349 a night for oceanfront rooms at this hotel, so people can extend their stay 5 days before or after. We negotiated that with the hotel, so you can make a longer trip at that rate. So for the beachfront rooms, so we really want this to be a special event. We're gonna have a really nice dinner for everybody Friday night. That's included off site. We're gonna take everyone to a really nice restaurant, and we want to build a nice community of like-minded colleagues to be able to then, like when you have a case that you're unsure of, and it includes also 6 months after this, approximately, we're going to do a virtual day together, and everyone's going to check in with those cases we treatment plan together in November. We're going to come in and we're going to do progress reports and go through the progress reports and look at how everyone's doing and help that too. Plus discounted coaching. And we throw in a bunch of stuff in there to try to make it, it's not your average, like go to sit in some lectures. This is it's going to be intense. But my goal is that Monday when people go back to their practices, they're doing this right away on their patients, and it will more than pay for itself very quickly, because we'll talk about how to bill for this too, how to appropriately charge for this, because you need to charge when you're the only one in your community doing this. You can certainly charge for your expertise if you're doing something different.
Sure.
So, yeah.
Sure.
Yeah, no, I'm really excited about it. Dana and I have been planning this. We started talking about it like in the fall, and being that it's in the spring now, we put it together, and we've got he's got video guys doing stuff. It's gonna be really fun. We're gonna have a really fun time.
Sounds awesome.
Make it a really cool event.
Well, can we keep talking? Can I wrap it up now, and then we can keep talking if you guys want?
Yeah, no, whatever you want to do. I'm happy to.
Okay.
Yep.
Okay. So thank you so much for joining us, Dr. DeLuke. This has been so informative, and I hope people's eyes have been opened just by listening to this. And you are a pioneer in your field, and we appreciate you. And I'm so happy that I found you on, I think, Instagram.
Hey, that's so crazy.
I know. Can you tell our viewers how to find you?
Sure. Yeah. And I have been so reluctant to embrace social media. I turned 50 in a couple months. I'm not the generation of my kid. I'm asking my kids, what do I do on Instagram? Facebook, I'm more than comfortable. So one place, I have the doc community on Facebook, which if you just go search that on Facebook, it's and then DOC doc community. You have to answer a couple of membership questions, and then I oversee the approvals. I'll let you in. It's open to it's not an orthodontic only group. It's general dentists, it's pediatric dentists. I have periodontists in there. I have oral surgeons. I have hygienists. I have myofunctional therapists. So it's it's a place where we can all collaborate and not feel like, this is all just orthodontists and they're not going to listen to me. I mean, it's really an open group. So that's one thing. Instagram is at the Ortho Coach. YouTube is at the Ortho Coach. So once I released that video on the white paper, my Instagram started blowing up, and I had never really done much on Instagram. I put stuff on my podcast episodes and stuff. And then all of a sudden it's so now I'm realizing that to really, my mission is to change the way early interceptive treatment is performed across the world in with a awareness of airway for young kids. And to do that, I've got to embrace social media a little more than I have. So I'm getting better.
If you need any help with that, reach out. I love social media. It's like my guilty pleasure.
And I don't.
Yeah, thank you. Yeah, I know. Yeah, I'm with you, Alex. It's tough, but I realize it's a necessary. So Priya, thank you for that offer as well. But I'm kind of learning and starting to figure my way around it. But and then I have the Doc podcast is really, I just released this week episode 159. Awesome. So I do weekly episodes.
I got to go back and listen to more, because I only listened to the one, but I'm excited. You've really opened my eyes, and just another avenue for us to kind of investigate and another path to hopefully go down. So I really appreciate it. And you have such passion about it. And that's really great.
I love it.
Thank you. To both of you. I want to thank the both of you as well, because you have to speak up, and you're busy, and you're with practices and families, and taking the time to do this. It's not easy. And I really respect that you're both taking the time and have the energy to do that. You could just put your heads down and do your work, and no one would fault you for it. But the fact that you're going above and beyond to spread this message is really awesome. And I appreciate it very much, because it helps for the overall mission as well.
Yeah,
sure does.
Great. Well, thank you. Thank you so much.
Thank you.
Yeah, thank you both.